Well, for those of you who know me, it's good to see you. And for those of you who don't, I am a cardiologist from the Cleveland Clinic that's positioned out here at Ashtabula on a full-time basis. There are two of us, myself, my partner, Dr. John Stevens. I've been here since February of last year, and John came and joined us just at the beginning of this year. So between the two of us, we are overseeing most of the cardiology here. Of course, we're working very closely with Dr. Cho, who's been here in the community for, I suspect, close to 40 years now, and a fine gentleman. So the three of us are intimately involved with overseeing all of cardiology here, providing as comprehensive a heart service for patients as we possibly can. I came here after a private practice career of about 27 years down in Stark County, Ohio, and then I joined the Cleveland Clinic staff after that. And so that's how you got me, or vice versa. At any rate, my training predominantly is in what we call interventional cardiology, that is doing stents and angioplasties and so on. But my practice has been that plus complete general cardiology. So we try to provide nice comprehensive service. Dr. Stevens has about the same background that I do. So between the two of us, we can get just about everything done that needs to be done for you. If not here, then at our main campus, which is probably less than 10% of what we do. So we get 90% of it done for you here in Ashtabula. Today, I wanted to talk a little bit about atrial fibrillation. We just recently had Stroke Week. Was it month? Was it Stroke Week or Stroke Month? Month. And so an emphasis on, in the public eye, stroke awareness and the fact that, as with heart attacks, when we had our emphasis on that, time is important in trying to have people understand, recognize, rapidly move to the emergency medical venue those people who are having a stroke. So what we wanted people to do is to be able to recognize what a stroke was, what kind of symptoms occurred, and the fact that getting to an emergency room within 10 minutes of onset of symptoms, if possible, is tremendously beneficial in strokes. Where that concerns a cardiologist is that one of our most common diagnoses in heart disease today, which is a rhythm abnormality of the heart called atrial fibrillation, is intimately involved with strokes. In fact, about 1/3 of the strokes in this country are believed to originate from atrial fibrillation. And so, in my work, identifying atrial fibrillation, protecting people from its consequences, especially stroke, and hopefully eliminating the atrial fibrillation in those people whom we can, becomes a very, very big part of what cardiologists in general practice do today. So, before I go on, anybody here unfortunately have any personal experience with atrial fibrillation? Okay. So, what we need to know about atrial fibrillation is that it is a rhythm abnormality of the heart. It's the most common adult rhythm abnormality of the heart, and it is an epidemic in the Western world today of rising proportions. When I trained, and that's going to take us back, since I have to date myself, about 30 years, atrial fibrillation was as well known and its treatment as well known as it is today. But I would see, in a very busy teaching medical center, we would consider it a busy week if we saw 2 or 3 patients a week with atrial fibrillation. Now that's in a 1,000-bed teaching medical center. Today, I would venture to say in this hospital, in my practice here, we see 5 or 6 patients a day with atrial fibrillation, either new onset or chronic. And so in the past 30 years, there has been a dramatic increase in the amount of atrial fibrillation we see in this country. Nobody's quite sure why. Whether or not our stock, our personal hardiness as far as rhythm is concerned. The heart is slowly diminishing with each generation. Whether this is some consequence of the environment or simply a consequence of living longer, as we have an aging population, we do not know. We do know that atrial fibrillation increases with age, but it also occurs in healthy young adults and even in teenagers. So we're not quite sure why this epidemic is occurring, but the epidemic of atrial fibrillation is increasing, and we expect even as much as a threefold rise by the year 2020 in the incidence of atrial fibrillation in this country. So what we're talking about here is something on the order of 15 to 20 million cases per year in this country, costing upwards of $500 million to $1 billion in healthcare expenditures. So we're talking about something that's very, very important, not only to the health of our society, but also to the economics of our society as well. And as I'm fond of saying, the atrial fibrillation is something that we either live with or get rid of, and everybody looks at me and says, well, that seems pretty logical. I mean, you don't have much choice, one of those two things. But the point is that we know that we can lead perfectly normal and healthy lives with atrial fibrillation as a rhythm abnormality and not have it cured. And yet, we could also lead perfectly healthy and normal lives trying to, with treatment to try to prevent it from occurring. We have a host of things that we do to treat atrial fibrillation, and I don't want to get into a lot of the details about how we try to eradicate it. But the most important thing that we want to see in the face of Stroke Month is that for those people at risk, which is almost 90% of the people that have atrial fibrillation, some form of anticoagulation to prevent blood clots and strokes is going to be necessary. And up until recently, we had just one available. Anybody here take warfarin or Coumadin? Coumadin.
I mean, I don't. My husband did.
Coumadin's been around for 55 years. And it has been the only reliable oral anticoagulant that we've had up until November of 2010. November of 2010, a medication called dabigatran was released by the FDA. It has some pros and cons. And in around September of last year, medicine called rivaroxaban was released. So we now have 3 potential anticoagulants for people with atrial fibrillation. And again, I don't want to get into the details of why one might be better than another, but after 55 years, we're still searching for the ideal anticoagulant for people. The ideal anticoagulant will probably never exist. That is the one that completely prevents people from getting abnormal blood clots and never causes them to bleed. And I can tell you that that would be a miracle. It's not going to happen. If we anticoagulate somebody, they're going to be at risk of bleeding. And if we don't anticoagulate them, they're going to be at risk of clotting. They're the 2 ends of the spectrum. We just can't get around. But the nice thing about the newer ones, and I think the ones that are coming down the pike, is that they're going to be much more reliable. They are going to be safer, not in terms of equal bleeding risk, but in terms of control. We're not going to have wide swings in large amounts of anticoagulation when we don't want it. The ideal drug is going to be able to be given and have an immediate effect, and stop taking it and be turned off in 24 hours. Warfarin Coumadin takes 3 days on and off at a minimum. So we're getting closer to having that ideal medication, and as we get closer to that ideal, we're going to see less and less strokes occur in this country. That's really the bottom line. Because the atrial fibrillation we can live with if it doesn't cause us to have a stroke. So a lot of what I do is counseling on how to prevent strokes. Now, the ideal way to get rid of the stroke is to get rid of the atrial fibrillation and keep it away permanently. Because if you don't have a rhythm abnormality, you don't need the blood thinner, and you're not at risk of a stroke, at least not from that cause. And again, one of the favorite lines that I have is that the perfect treatment would make sure that your atrial fibrillation never comes back. Who wants to tell me how long never is? Well, never is something that you can only hope for looking forward and prove looking backwards. Never is between now and when it doesn't count anymore. And there's only one event in life that makes it not count anymore. And when we get there, we don't have to worry about it anymore. So if we're looking forward, the medication that prevents atrial fibrillation to the extent that it never comes back hasn't been invented yet. So all of our rhythm regulating medications are good at perhaps reducing some of the risk of it coming back. But what we really want to know is not so much that it doesn't come back, but I can take you off of an anticoagulant if I get your atrial fibrillation reversed back to normal rhythm. And if you can tell me, if you could call me up on the phone in less than 6 hours that your atrial fibrillation has come back and tell me about it, well, that's a problem. Because atrial fibrillation, with the right medication, this rhythm abnormality of the heart, so common as it is, may not cause any symptoms at all. So you have no idea that you're in atrial fibrillation, and that's the scary part. We've got lots of people out there walking around with atrial fibrillation at risk of having a stroke, and they don't know it. And we don't have a good method yet of figuring out how to be warned when it happens. Probably someday we will have some type of monitor. It's like when you're driving your car, if the oil pressure drops, the light comes on, the buzzer sounds and tells you, oh, got an engine problem. So we need to install some kind of monitoring system that beeps, buzzes, lights up, or otherwise warns you when your atrial fibrillation comes back. And we don't really have that yet. We do have it for people that have a pacemaker for other reasons, but since pacemakers don't get put in for atrial fibrillation, we don't have the ability to do that for everybody. So, but some pacemakers are pre-programmed to be able to warn us, or actually warn the doctor if atrial fibrillation has recurred. So, what we have is atrial fibrillation and irregular, sometimes rapid heartbeat. It can come at any moment for any particular reason. It's not necessarily something that you do, or it's not something you're exposed to. It just starts up when it wants to. It's probably caused in part because our hearts were designed somewhat differently, or excuse me, somewhat incorrectly by the original engineer. Now we're not allowed to really say that because that goes against some people's ethical and moral grade. But there is a design structural problem that probably has to do with why atrial fibrillation occurs. The longer we stay healthy, the longer we have a likelihood that we're going to develop some of these nuisance type maladies that occur as we age. And unfortunately, this one tends to be common, tends to have minimal symptoms, but has one drawback, and that is it can cause a stroke. So on the first aid side, we try to recognize those features of a stroke, and that's what the purpose of our last month has been with Stroke Awareness Week. We have a stroke, we're a certified stroke center here, so that our emergency department is particularly adept at identifying, diagnosing, and initiating the treatment for strokes when they occur.